Good morning, everyone. It's truly a pleasure for me to welcome Dr. Ana Nunez today. I have to give the caveat that Dr. Nunez and I go back to my days as a junior faculty member when she was chief resident at Hahnemann. And she's had an absolutely stellar career as a champion of women and underserved communities. She's a professor of medicine and serves as the Associate Dean of Diversity, Equity, Inclusion, and the Director of the National Center of Excellence in Women's Health and Women's Health Education at Drexel University in Philadelphia. She did all of her training at Hahnemann in internal medicine, where, as I had mentioned earlier, she completed her residency and did a chief residency. And then she's done additional education over the years, including fellowships in medical education, health services research, health policy, and she also completed a fellowship at the very prestigious ELAM program, Executive Leadership in Academic Medicine, which is a program to develop women leaders. She's nationally recognized in both education and health services research. She has served as the principal investigator on numerous educational and health services grants. In her current role, she spearheads an agenda of organizational change and provides leadership to promote excellence in her college, which also supports a mission of quality education and care by augmenting diversity and inclusion with faculty, students, residents, and staff. Her collaboration promotes researchers, educators, and community members to address critically needed and practically focused health disparity issues. She's received numerous awards, a number of teaching awards, alumni awards, but most recently she was the recipient of the prestigious Herbert J. Nickens Award from the AAMC, which is given to the physician who most promotes social justice and medical education. She's also the editor-in-chief of the journal Health Equity. She serves on a number of boards, including a board for Women Against Abuse. So please join me in welcoming Dr. Ana Nunez.
Thank you so much, Dr. Raboli, for that wonderful introduction. Okay, this is great, this setup here. It's like, I feel like we could have like a dinner for six or something. It's pretty cool. As I wander about, I just hope I don't hit myself. All right, okay, so I was asked to share with you everything you needed to know about including LGBT health in medical education curriculum in 50 minutes. Okay. So what we're going to do in terms of the time together is really talk a little bit about some definition and terms. We're going to talk a little bit in terms of sort of curricular sort of change and reform, a titch about concepts, and then some tips in terms of how to put it together. So, cultural effectiveness, population care, sexual minorities and terminology, orientation, behavior, identity, and gender continuum. Are you ready for curricular change? Cross-cutting issues for sexual minorities, status on medical education effectiveness, and some examples of content. So I would submit to you that the answer to the question of how do we do this is to do it how you're already doing it. I would assume in terms of population-focused care, you're focused in terms of various race, ethnicities, groups, vulnerable populations, and so how you address population care is sort of the same approach you should in terms of individuals who have lives that are within the group of sexual minorities. And so some of those principles in brief is balancing seeing the individual, what they bring to the table, with what you know or may be aware of in terms of their culture, seeing both. Being avoidant of stereotype in terms of, oh, if this is the demographic, we must be saying this, and sort of avoiding that. The limitation of insight in terms of we may have some awareness in terms of sociocultural determinants of health on individuals that they themselves in their lived experience don't really see. And the importance of making unconscious bias explicit because what we see in terms of evaluating somebody might not actually be who they are. We need to sort of make room for that, shine the light on bias, and see that individual, what they bring to the issue. And then finally, recognizing the limitations of patients divulging information. I joke with our students that we have this expectations of doctors, right? That when patients come in and we say, we want to see it, and we want like, wow, see everything. And patients are like, okay, here, this is what you get. And you're like, well no, I want here and here and here. And they're like, no, I don't know you from Boo. Like, this is what you get, right? So patients may not necessarily share with us until the point where they feel that they are safe and able to sort of connect. So when we talk about sexual minorities, let me just share with you that, and I'm going to come from this from an old-headedness. I really am going to move this because I'm going to hit myself. I'm going to come to this from an old-headedness. So I'm going to talk about sort of what we used to think and where we are now. And so for those of you who are sort of younger in the audience, you're like, really? That's what they thought? And for the people with a little bit of gray hair, you're like, yeah, that's what we used to think. So I want to sort of do that contrast because it's useful in terms of understanding where are we now. When we talk about sexual minorities, definitions are groups whose sexual identity, orientation, or practices differ from majority. Subgroups include those who are listed as lesbian, gay, bisexual, or transgendered people, or one of the acronyms LGBT. There's lots of acronyms, okay? There's lots of acronyms. This is like MOUSE. Okay, you know, instead of LGBT, there's LGBTQQIAAPP, with all of these different things. Okay, so, and you can sort of see in terms of a certain extent kind of where we're going in some of this, but there are some who suggest, thankfully, that we either say sexual minorities or gender and sexual minorities because it's just too hard to say all the letters in the alphabet and remember what they stand for. Within sexual minorities, some people have differences in sexual development, and the buzzword for that is DSD. Differences in sexual development, which basically is that biologic and anatomic sex is not synchronous with perceived sex. So cis woman versus trans woman, these terms you'll hear in terms of cis and trans. Cis means like chemistry. I know there might be a little PTSD of thinking back to chemistry days, right? Okay, but a cis woman is a woman who is biologically, anatomically born female, who then identifies as female. A trans woman is an individual who was not born female, but identifies as female, right? So they were born biologically male, but identify as female. So we have cis and trans. Other people within the alphabet, DSD generally refers to people who are transgendered individuals. So generally, just in terms of some quick demographics, there's a range in terms of how many individuals are within the space of sort of LGBT so far as population. And it's important to recognize as you look at some of this data that the range varies widely, that we actually had been just in the process of getting good numbers. And the reason that we impeded having good numbers is prior to the recent past because of discrimination in terms of housing, in terms of employment. It's still even in the Commonwealth of Pennsylvania, you know, that state over there, that you can certainly have federal rights in terms of protection of marriage, but in the suburbs, if you put a same-sex picture of an individual and talk about what you did with your wife over the weekend, you could be fired because there's no protection in sort of suburbs so far as you can be fired because of being gay. So there's lots of numbers that we see here. The range basically says about 2 to 9 million, with a population doubling of that by 2013. Same-sex lifetime behaviors, 8.2%, attraction 25.6% or 11%, and substantially higher than the numbers who actually identify as lesbian, gay, or bisexual. But let me just backtrack in terms of sort of some of these words, because these words are really very important, and I will preface it in saying it used to be not so confusing, and now it's kind of confusing. All right, so it's important that we sort of talk about what this means: orientation, behavior, identity, expression, and the gender continuum. So what we used to think is, at the center of everything is sex and gender. And that sex and gender, pretty much we're just, you know, walking on the same track. And with sex and gender, there's orientation, behavior, and identity. And specifically when we talk about orientation, identity, and behavior, I think it's useful to sort of look at what we mean. So orientation is who rocks your world. Who do you see that you go thump, 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 thump? Okay, that's orientation. Who do I gravitate to? Who rocks my world? Identity is who I say I am in terms of sort of my self-expression. And then behavior is the do. And as clinicians, we need to know all of these. We need to know who rocks your world in terms of to whom you gravitate, where are your social support, who do you look for. We need to be respectful and understand who do you say you are. And then fundamentally, we need to know what you do. Because in terms of sort of assessing risks, we need sort of all that information. Gender identity is developed from emotional and psychological responses, societal expectations, individual development over time, and we'll talk in a minute about identity and orientation and behavior. But here's what we used to think. We used to think life very simple. Number one, we were all like those bathroom signs. A woman looked like the woman, and the guy looked like the guy, although if somebody actually looked like that and they walked in here, I'd be very frightened. But we used to believe that there were these sort of almost cartoony things, male, female, only binary. We used to say that basically we confer male, female from scrapuchal mucosa, XXXY. And the final say, if there was any ambiguity, is you look to what you're packing. And so anatomically, sort of that defines what you are, end of game, period. Gender, which is about lived life, in contrast to the biologic description, was also viewed in a very sort of binary and sometimes rigid, so sexual stereotype kind of way. We used to think that orientation was also binary, towards men, towards women, once in a while, maybe both, but generally sort of binary. And sexual identity, again, defined as what you see yourself as and what you say you are. And so now, we actually are in a space for which sex is biologic and anatomic, but not necessarily binary. That gender is on a spectrum and absolutely not binary and fluid. That sexual orientation can be fluid. That sexual identity, like all self-expression, is what you identify and what I have to figure out, so to be respectful of you, and is not exactly defined, per se, by anatomic-born sex or even sort of gender expression. Sexual behavior is still the do, but I have to sort of figure out in details, and I need to ask, not assume. So now we're sort of in a space when we look at things of who is this individual, about sex, anatomic, cis or trans, function in terms of sexual organs, identity, and expression, as well as gender being orientation, identity, behavior, and expression, with these things sort of changing up a bit. So this is the gender-bred person, or the new and improved gender unicorn, just to sort of make things sort of a little confusing. And there's lots of people who say identity, sex is in your perineum, identity is in your brain, and orientation is in your heart. This certainly is reductionistic because I think in terms of sexuality, we have lots of neurologic evidence in terms of sexuality in our brain as well as in our gonads, as well as sort of orientation. But for purposes of understanding, here we have the spectrum rather than the binary in terms of identity, expression, biologic sex, sexual orientation in terms of, and then sexual assignment as we sort of move through this. For those of you who are interested, Katie Couric recently did a special, and the most recent issue of National Geographic talks about the gender revolution in terms of individuals and sort of the spectrum in terms of gender expression that exists. It's sort of useful in terms of exposure and gaining understanding. This is actually a picture researchers actually did, and they said, here are morphologic features in terms of maleness. Supposed to work. On the far left, A at the negative 200%. This is not working. Okay. A at negative 200%. Physical features of sort of maleness, all the way to the positive 200% of physical features of femaleness and the spectrum thereof for both panels. Sort of speaking to the issue in terms of, even if we look at sort of physical characteristics, size of cheekbone, distance between nose and sort of lips, and so on and so forth, that changes in terms of shapes and faces of women and men, we see that there is sort of a range. And if you look in the -50, or in the 0 rather, you'll sort of see with those individuals, if you saw those individuals, put them in a dress, you might say, that certainly looks like a woman. Put them in a business suit, might look like a guy, right? Because they don't necessarily look as strongly in terms of those physical characteristics one way or the other. And so when we talk about sort of some of the androgyny, some of the challenges we face in terms of saying, hello, ma'am, hello, sir, and getting it right, and not being off-putting from the get-go, we need to consider elements in terms of the gender continuum. Bless you. Another example in terms of the gender continuum is, again, sort of how people can attire in terms of expressing their gender, right? And so, you might say, wow, a guy in a skirt for real? And you're like, ever see a Scotsman? Guy in a dress? Ever see somebody from the Middle East? So we have these models, and yet when we sort of have the skew very narrow, we say, nah, that's not sort of usual, that's sort of unexpected, and yet those models sort of exist. And the question is, are we sort of expansive enough to sort of take where are people sort of coming from and who they are? Again, here's another example. This is the same model, And yet there's elements in terms of looking at this individual, a little bit in terms of the lighting, probably a little bit in terms of sort of makeup of highlighting or diminishing sort of some shadows, issues in terms of even physicality, right? Woman is all sort of hunched, vulnerable, et cetera, with her little fishnet stockings there, and the guy sort of appearing, sort of showing like good hair on the arms and big biceps. Although there are some, the gal actually looks like she has biceps, but she's hiding them. But when we look in terms of fluidity of expression, we aren't the bathroom signs in terms of male and female. And it's important for us to understand that because more and more individuals are taking advantage in terms of gender expression and resisting sort of the binary. There's additional sort of components in terms of gender. Queer used to be a term that was fighting words. It was a word that was sort of, bless you, about sort of derogation. But now, especially in young adults, queer is actually an empowerment word. But I do think that sort of queer is kind of a word that in culture can say about each other, but somebody from outside, be careful of that. Because it might not be so empowering, it might still have that derogation. Genderqueer is a term used by individuals who identify as neither entirely male or entirely female. And Two-Spirit is a historic term that comes originally from First Nations people, who are individuals, spirits, who were blends of male and female spirits. And so it's sort of an honor in terms of LGBT, so far as a two-spirit sort of approach. It's important to recognize, in terms of understanding issues about pronouns, and you're like, pronouns? He, she, hello? Okay, so if we think in terms of gender expression, and somebody says, I'm not binary in terms of male or female, I'm gender nonconforming, then how do I refer to you? Because binary means you say she or he in terms of sort of binary. And so if I reject those, then what the heck do you call me? And in sort of gender pronouns, and which is especially important in terms of respect and sort of broadcasting not being transphobic, are issues in terms of appropriate sort of designation. So imagine a transgender patient goes by the name of Sally with a birth name of Sam. Just even in terms of that, right now, Sally comes to your clinic. Sally sort of writes in the form, my name is Sally. And we all, dear God, fearful of Medicare fraud and Medicaid fraud, right? We need all this paperwork. And so we say, give me an ID. I want to make sure your insurance is yours and not somebody else's. And they hand out their ID, and their ID says Sam, not Sally. And maybe their picture looks different than their driver's license. So does the front desk staff say, oh, scam, this isn't your health care, go away, never mind? Probably, right? Because there's sort of that confusion of, I have to match the picture with your name, with your insurance, to say it's okay to come here so we don't get in trouble. So that's issue number one in terms of transgendered folks, so far as things. But now, Sally, you overcome that hurdle because of your unique brilliance and wonderful training at your front desk staff that sort of transgender folks may have issues here, and you've sort of figured it out because you're brilliant. And Sally's now back in your exam room. And you walk in the room and you say, hello, Sally, how are you? And Sally starts talking. And as you're sort of referring to her, do you call her she? Right, because Sally's a trans woman. So do you call her she? So you would say, well, her name's Sally. She's anatomically born a man. She's transgendered, so she is a trans woman. So I'll call her she, right? So she should be the right answer. But pronouns are about self-identity. So the only way to know the right answer as to what pronoun to ask to use with Sally is to ask her. Because Sally might want she and be totally bent if you don't call her she. But Sally might want they or Z. Now, for those of you who a million years ago were English majors, this is going to make your head spin. How can a pronoun that is singular, plural, be used for singular? But deal with it. It's just the way it is. we're throwing, I think in the world of text messaging, I think it's safe to say that a lot of English grammar has gone by the wayside. So we're in a new day. So they is sort of the word, even though they is meant for the singular. And so what we need to do with Sally is sort of do a, hi, Sally, and again, a little telescoping in terms of saying, I know about the pronoun thing. I know one thing about maybe transgender folks, is I say, hi, my name's Dr. Nunez, nice to meet you. My pronouns are she and her. Sally, how would you like me to call you? And Sally may say, my pronouns are she and her too, or Sally might say, I'd prefer you refer me as they. Okay? So again, important to sort of be aware so far as pronouns and kind of getting it right so we don't sort of estrange patients sort of from the get-go. So here's just a look in terms of how, again, for the former English majors, of how to wrap your head around this. They are speaking, meaning she is speaking. I listen to them rather than I listen to her or him. The backpack is theirs. And again, they is probably far more, in terms of my limited experience, more used, bless you, than Z, Zer, or Zers, or Zers Health. And I don't know whether that's sort of a regional thing or whatever, but in terms of sort of the exposure I've had, they is really sort of used a fair amount. So then we talked about behavior of what do people do. And if you look in terms of the CDC, we have WSW, WSM, MSW, MSM, right? Women who have sex with women, women who have sex with men, men who have sex with women, men who have sex with men, right? So we have sort of these labels, and when you look in terms of MMWR and infectious disease kind of things, nod to Dr. Raboli here, in terms of these things, we have sort of the behavioral issue. But the challenge is that MSM or MSW are describing binary choices, right? We're sort of back to sort of the bathroom signs in binary. So how do you refer to a heterosexual woman who is intimate with a trans man? Because if you have women who is having sex with a man, we in medicine apply some anatomic pieces to that, both in terms of the behavior as well as risk. But a trans man may not have transitioned to have anatomic changes that sort of qualify for the woman having sex with the man in terms of how we mean it biologically. Does that make sense? Okay, so as I said, it's complicated. We have to sort of think about sort of what are we saying and what are we meaning in terms of imparting risk. Now the other piece, because it's just not complicated enough, is we need to look at behavior, identity, and desire. And newsflash, they don't all run in the same lane. We can have an orientation in one direction and a behavior in a different direction. We can have a desire in one direction and an identity in another direction. Based upon the literature, women who self-identify as lesbians, about 75% of the time within their lifetime, have had sex with a man. So if you think lesbian is, by definition, a woman who only has sex with women, well, maybe that's true now, but maybe not all the time, or maybe not even this year. And so the only way to understand about behavior is to ask. Important to ask. We can have individuals who say, oh, I'm straight. And then when we ask the do, they have sex with a man, has sex with a man. But they don't identify as a gay man. They identify as a straight man. So again, it goes back to we have to be able in the lane of sort of ask, who are you? How do you self-identify? As well as what do you do? Because things don't all sort of run together. So we talk about sort of, what do we need in the curriculum? And I guess the first question, for which I don't have an answer, but you all do, what is currently in your curriculum in terms of LGBTQ health? And then here's some just general principles about sort of curricular construction to sort of make sense. When we create a curriculum, it isn't, believe it or not, for the objectives that LCMA tell us we have to do. It actually isn't for the objectives in terms of the course that we're actually putting together. The point in terms of developing the curriculum is what are the real-world experiences, challenges, and issues that we need to address? And from those real-world issues, what are the objectives that we need to teach in order to have the outcomes we want? Right? So we're all here in terms of good quality patient care of diverse populations. And so the question is, what are the real-world experiences that we want to sort of use as, if we've done our job so far as training people, so far as LGBT health, they're going to be able to take good care, high-quality care in terms of patients who belong within those groups. So we want to think about first, what are the real-world performances? What are the examples around? What are the examples out in the world that we expect people to do? Create the terminal objective. Think about how to best convey that so far as methods, infuse appropriate sequence content, and then, of course, most importantly, how do we know whether we did a good job? Evaluate to see whether or not what we thought we did, we actually did. So here's sort of the journey in terms of, where are we now? Where do we want to be? What do we need to do to get there? And how the heck do we do that, right? So doing a needs assessment in terms of analysis of existing data, current coverage, impact from courses, preceptor and student feedback. And I would submit to you that this should both be qualitative and quantitative to really get how much as well as how. A literature review in terms of what are other schools doing or what's on the national stage. Structured interviews in terms of opinion leaders, former leadership, and anticipated barriers. Written questionnaires, group meetings, direct observation, and performance of those who are currently teaching. But I think an important question in your needs assessment needs to be, what is your institutional climate about? Does it support the curriculum? So quite a number of years ago, I was invited to a school that shall remain nameless to do sort of a curricular session actually on LGBT health inclusion in their curriculum. And as I started talking about it, I said, well, what do you do, for example, in terms of other sort of sensitive topics? Because someone's sort of saying, in terms of sexuality, that can be potentially sensitive. Do I feel safe? Do I divulge? And I just sort of pulled out of the hat, if somebody in terms of their substance use or abuse, like how do you teach about sort of that sensitive sort of issue to make the patient feel safe? And a number of the faculty members said, oh, dear God, we don't talk about that. We can't talk about that because, it's really stigmatized, and everybody sort of, makes fun of people who are, drug users. And so we can't do that. And I'm thinking, okay, so much for safe. Okay. Like, can you get there from here? Not yet. So it's important in terms of looking at institutional culture, what's the status around? Sometimes what happens with curriculum is we get so laser focused like we are in terms of taking care of patient that we forget about student life and institutional life and what are the messages. And if an environment is hostile in terms of LGBT issues, if it's still like the third grade locker room in terms of that, it's very difficult to sort of send a message in terms of inclusion about sexual minorities if in fact sexual minorities don't necessarily feel safe in terms of the institutional climate. So looking in terms of critically, what's the environmental status for learning, teaching, patient care, staff, and professional staff as it relates to LGBT health and wellness, looking at policies, practice care standards, visibility, health education, and community outreach is really important. I show up here on the far right for you, we have 7 principles about being safe that we use that comes from Sandra Bloom's work in terms of sanctuary and about a safe, inclusive culture. Bless you. And so having those principles in terms of that's what we work around to expand is important to share attitudes. When we drill down to the learning climate, how much does your climate support your curricular messages and vice versa? There are things like safe zone training, safety training, ombudspersons, and also what led to the optics in your institution. Are there role models? Are there positive images, not just deficit or negative ones, in terms of LGBT health? and sort of how are they conveyed. If every single clinic or office site for their patient education brochure only has images in terms of heterosexual individuals or non-diverse individuals, you're sending a message, even just by having that sort of around the office. And so what are the images in terms of sort of inclusion? Safe training in terms of how do we create a safe environment and a safe culture are sort of ways to sort of be able to do that. Safe zone training is a specific type that sort of gets into more in terms of issues of transgendered health, as well as sort of what are the right pronouns and how to be sort of inclusive. Many places have ombudsperson who will have signs like ally underneath to sort of say it's safe for lots of folks. And again, it's important to sort of include this in your environment. So for your framework, you need the planners. Who are going to be the faculty? Who are the champions? What is the faculty development? About 28% of faculty admitted personal knowledge deficits impeding integration of LGBT education in the curriculum. What's the content and processes you're going to use? Where are you going to put it? And who are your implementers? It's important up front to square one, sort of identify these barriers and look at interventions so far as these barriers, rather than sort of go through the process and kind of get stymied or stuck in terms of some of them. So in terms of attitudes of faculty, most faculty, in terms of studies that have looked about LGBT medical education inclusion, reported that it was an important thing to include. Of students, there was a wide variety of people who, I don't think I ever met a gay person, to let me go teach you about pronouns. So there's a wide range in terms of expertise and awareness of our students. Knowledge, I mentioned in terms of limited self-knowledge of faculty. Perspective in terms of full scope. Okay, and again, I think that sometimes what happens in terms of LGBT is, okay, the part that's going to really kind of be difficult for me is to ask you a question about the do of your behavior. So if I'm going to teach about LGBT health, then maybe all I need to do is talk about sexual history taking and I'm good. I would submit to you that for patients who are Hispanic, African American, Hmong, Italian, whatever, asking just sexual history and saying, in terms of population health, we're good, because I asked your sexual history. The reality of it was when you talk about a population, it's far more than the do of sort of sexuality, and so we need to sort of have the appropriate sort of scope and perspective. For skills, certainly communication and awareness barriers that students might have, and formal training by facilitators and educators in terms of talking about these things. Many years ago, many years ago, we had a problem-based case, and the case was of a woman, Charlotte, who the students were supposed to, be taken care of, and Charlotte gets bad news. She has endometrial cancer. And so the case was to deliver this bad news for poor Charlotte. And so as the student is delivering this bad news, unbeknownst to the student, the standardized patient was lesbian, and her partner, Carolyn, of 20-some years, was sort of in the wings but sort of not involved. And the case was a bit of a setup in terms of sort of bad news and who's your support person to sort of talk about this bad news in terms of next steps and things like that. And so the oops in the case was that most people asked her, well, maybe you should bring your husband to the next visit so we can talk about sort of cancer care, rather than asking who's home with you, who's your point person, or whatever, and having her divulge this individual. So we had to do a training for SPs, which was just so much fun. Train people how to be lesbians. Okay. Okay. So we have these lovely standardized patients, these very nice ladies, a wide range of age from sort of 30s to 65. So we're doing this training, okay? And we're going through all this sort of training. And for those of you who have the opportunity to work with SPs, they are lovely individuals, but they're really good in terms of details. Is it on the checklist? If it's on the checklist, it is. And if it's not on the checklist, it isn't. So what I do is on the checklist, and if it's not, oh my God, I don't know what to do. So we go through this whole thing, and the ladies are like, well, when the second-year student asks us, do we come out or not? And I said, well, if you feel safe and that they make you feel comfortable at the level of skills of a second-year medical student, then yes. And if you don't feel safe, then no. Their PET scans like, no, it's either on the checklist or not, right? So they're having a heck of a time with this, right? So we get past this, right? And so we're there, and they're still sort of, right? Okay, we've finished. It's now 90 minutes in, and they've asked all these questions, okay? So like we're almost good to go, almost out the door, okay? And this one lady sitting over in the corner said, Dr. Nunez, I just have one last question. And she goes, I just don't understand the case. Because if Charlotte's getting this news of endometrial cancer, like, why doesn't she bring her daughter rather than her partner? I said, okay, let's put a protective bubble over you that nothing bad ever happens. It's a great bubble to have. Okay, nothing bad ever going to happen to you. Okay, now let's assume you're Charlotte and you're getting this diagnosis. Do you bring your husband or do you bring your daughter? And she goes, well, I bring my husband. And I said, why? She goes, well, because he's blood. I'm like, I'm scared. There are consanguinity laws, okay? Okay, that's not what she meant. And she goes, well, but he's really related to me. And I was just like, okay, isn't that the point? In terms of who's my spouse, who's my partner, who's real. A colleague of mine, in a case, I'll show you the face of the case book. He has a case about sort of HIV, and he's a great guy, really, really great guy. But his case is about a patient who comes in who's HIV positive, living in his family's home, but tells the physician, I'm gay, but my family doesn't know. And the next time you meet this fellow, he's dying in an intensive care unit. And rather than be inclusive and address the partner's wishes, the critical care doctor actually outs this dying man to his family. And the analysis in the book talks about like, well, kind of family first. You have to. The family has the right to know because sort of what's he, the partner, to this guy anyway. In addition to violating Pennsylvania law, this is also sort of a wrong thing to do. But his perspective was it never occurred to them that family wouldn't be supportive of an individual and that there would be repercussions. And so it's important that even well-meaning people do the best they can, sometimes sort of do the oops and ouches we have to pay attention to. So in curriculum, we have review, looking at content, proposed changes, buy-in, implementation, and outcomes. According to unique health issues, there are cross-cutting issues. And the reason I sort of point this out, and this is looking in terms of LGBT health, but think about in terms of other population-based perspectives that you're already teaching about. Minority stress, life course, intersectionality, right? I'm female, but I'm also Hispanic. I'm not just one thing. Nobody is just one thing. Social ecology in terms of sociocultural determinants. Those things probably already exist within your curriculum. You already have templates in terms of population care, and now how do you expand them to look in terms of LGBT, social influence, healthcare inequities, intervention research, transgendered specific needs. It is important in terms of all population, especially minority population issues, looking at trauma in health. We could sort of change this in terms of individual, interpersonal, and structural stigma to sort of include instead racism, sexism, name your ism, in terms of various levels that sort of impede, and a separate talk would be about sort of just trauma and health. But LGBT individuals face health disparities. There is overt and unconscious bias that play roles. Medicine, sadly, currently contributes to these disparities, and it's our duty to deliver high-quality care. Just sort of quick fact in terms of when we look in terms of suicidal attempts, if a youth is gay or bisexual, 4 times the rate of their peers in terms of attempting suicide. Why do this? There's also sort of both carrot and stick. The stick in terms of LCME requires as such, and to sort of show it and where in terms of your evaluation. How well medicine in general is doing? Not so much. Medium LGBT-related content. This is a 2011 survey from colleagues at Harvard, about an 85% response rate. Medium was 5 hours. And the percent of the quality of that that was very good or good was only about 24%. So certainly we can do better. AAMC recommendations are about communication training, of course, as well as comprehensive curricular reform. And again, their encouragement is to ensure students master knowledge, skills, attitudes to provide excellent and comprehensive care to LGBT community in terms of issues. The perception of adequacy and knowledge generally, as I mentioned before, was low. I'll just point out to you here, how to direct patients to LGBT-friendly care was a whopping 9.3%. in terms of sort of standards back in sort of 2010. I wanted to just quickly run through sort of content issues. This is probably more useful as a handout, which I'm happy to sort of turn it into if people are interested, but I just kind of want to give a quick scatter plot in terms of things. When we look in terms of patient care, how do we deal with an infant with ambiguous genitalia, right? Back in the day, it was, well, it looks to me like that's a boy, or it looks to me like it's a girl, and that's how we'll raise them. But now in terms of sort of that gender identity, at what point do we sort of say, you know, sort of where we are and how we're sort of moving forward in terms of an understanding on the gender spectrum? Knowledge for practice, issues about gender dysphoria in adolescence, practice-based learning and improvement, optimal care of a transgendered man with a pelvic mass, interpersonal and communication skills using gender-appropriate nouns, communicating bad news to a lesbian, as the example I gave, discussing risk factors to a heterosexual man who has sex with men and women, and professionalism, how to deal with team members who are inappropriate to DSD patients. On a system-based practice, how do we capture SOGI? I love that. Sexual orientation and gender identity. It sounds like where we had the Olympics, SOGI. SOGI in the EMR, using a body map. Interprofessional collaboration, interprofessional care for a newly diagnosed teen, gay teen with HIV. Personal and professional development, working with LGBT colleagues. I rarely do something like this, but I said this back in 2003, and it still is germane, and that's about sexual health. If we don't do vanilla, you can't do the other flavors. You really have to look in terms of how do we address sexual health in the curriculum period. It's actually harder than you think because of the oversaturation and sexualization, you know, porn central everywhere in terms of issues about being able to actually really sort of appreciate the art of the human body, be able to do a breast exam by a man without sort of going to like the cable porn place, being able to do sort of a sensitive pelvic examination and understand what's going on and be present in a professional fashion. Those issues get in the way, not only just for us as physicians, but also for our patients in terms of appropriateness about boundaries. So understanding about how we teach about sexual health, even just heterosexually in that space, needs to be sort of like, of course, duh, rather than something that's prurient. We can't have, there was a primary care text that I was asked to review. And I went through, as a general internist, I go to this primary care test, this looks really good. And I realize that it is if there's two black boxes in this text. There's nothing here in primary care, and there's nothing here, like sort of FDA black box warnings, okay? Right, so the message was, if you're a generalist, like you don't touch this, and you don't touch this. And I'm like, what? Right, and these are very prestigious people who did this book, and they were like, you know, very important people. And I'm like, my feedback is like, you're missing two areas of the body in terms of breast examinations, hernias, and so on and so forth. And they didn't notice. They didn't notice because they didn't necessarily feel in primary care that that was sort of appropriate. The literature actually says that in the US, as much as we're oversaturated, we're kind of prudes when it comes to sort of sexual health and sort of having sort of forthright discussions about sexuality, and we kind of have to get over that to be better. I will share with you in terms of general go-tos that when we talk about attitudes like empathy and awareness of individuals with limited exposure, having panels with real-life people or videos can evoke awareness. Most recently on TV, When We Rise is sort of something that came out. If These Walls Can Talk Too, Queer as Folk, The L Word, The Band Played On. There's lots of sort of videos that are available. When we look to include content, invite students to help generate content. They may bring sort of a wealth of their experience that we can then attach in terms of healthcare situations to create some really sort of elegant and robust sort of interventions. I mentioned about introductory sessions, avoidance of stereotypes and of teaching of them, inclusion of wellness and illness, not just here's the person and here's the deficit. And there's lots of resources available, lots of different places. This is the textbook I meant. This actually has cases, and these cases were predominantly founded. I was one of the associate editors in this. It's predominantly funding came from NHLBI, so cardiovascular related issues as well as some infectious disease topics are covered within this. But the point of this is the disease is an issue. You're all expert. You can teach about current concepts about sort of disease management. This is all about sort of context of care. Who's this person, what's going on, et cetera, that is useful in terms of sort of embedding it in the socio-cultural context that might be useful. Again, lots of resources available in terms of issues. I put the 2003 and the 2011 sort of reports side by side because sadly we've made so much progress that they're kind of pretty much the same. So we still have the same issues to address. Generally, in terms of LGBT, when we look in terms of sexual orientation and health status, it is fair to poor, with higher levels of disability, smoking, obesity. And when patients are concerned that healthcare providers might have animus towards them, sadly there's sufficient things in the resource, in the literature that say that's not an illegitimate concern. So it's important, and so sometimes it is, you aren't who I thought it was, you know, and so like, how do I deal with that? Versus there is animus because like, where is your husband? And that's who I want you to be, and if it isn't, then suddenly you fooled me, and so how do I sort of deal with that? This is just a quick list that's well cited in terms of health disparities with smoking, substance abuse, high-risk sexual practice, substance abuse and high-risk sex, eating disorders or high-risk weight control, less exercise and sports. And again, sort of, you know, it stands to reason and is pretty obvious that if you're a gay teen, the gym and locker room is not exactly a safe space, and not necessarily one of inclusion. There's a recent documentary about Greg Louganis in terms of his various, like 5 gold medals, and yet, you know, he wasn't on a Wheaties box because there was a morality clause and they didn't want to include him in that. Victimization in terms of LGBT people, lots of sort of issues with this, chronic disease, obesity, asthma, cardiovascular. And as you look at these issues, I challenge you to sort of say, where do we teach about this? And what are the cases that we use? What are the examples? And how can we reflect this? As I'm talking about sort of cardiovascular risk manifestations, how do we sort of include this to include the population? Sexually transmitted illnesses, care delay or denial of care, anal cancer, mental and behavioral health issue in terms of suicide, substance abuse, depression. Again, sort of LGBT individuals have twice the life risk in terms of traumatic experience compared to people who are straight. And just generally, sort of again, here's sort of, again, where in the curriculum do you cover these topics? And how in the curriculum do you include this population as you sort of talk about these? One issue I'll tell you in terms of sort of gay men is that actually a lot of sort of gay men will say, you know, if I come to my primary care doctor's office for a cold, you shouldn't sort of check an HIV status on me every time. Hello. You know, like for my annual, yes, with a new partner, I get it, but like I'm there for a cold, for real. Like the only thing you know is to check my HIV status. Not that in terms of risk issues, we need to sort of know about that. But again, sort of what's the message we're sending when all we think about is sort of your sexuality. Bisexual patients, it's important to understand, especially in terms of the do, because the do is going to derive what do we say as risk, and therefore what is optimal sort of care for them. Transgender patients, of all patients, kind of in the alphabet, actually have the worst care. There's a report that I'll show you in a minute, but issues of violence, mental health, substance abuse, there's some really sort of lived lives in terms of transgender patients are really generally kind of awful. And I think that images and icons like Caitlyn Jenner sort of do a disservice because nobody's like Caitlyn. Most of these folks, sex workers, assaulted, HIV, impoverished, difficult to get a job, they have really, really harsh lives. And so they are most vulnerable in terms of issues. There are issues in terms of female to male at risk for endometrial cancer, male to female with prostate cancer, hormonal complications, and sexual reassignment. And actually, I learned recently that's the wrong word. It's sexual affirming surgery rather than reassignment in terms of sort of being able to understand that. This is the Injustice at Every Turn, a report on the National Transgender Discrimination Survey. There's lots of information in terms of issues about sort of transgendered health and discrimination. As I mentioned, in the real world, the patient intake experience alone sort of can be challenging for individuals. Do we have sexual orientation and gender identity in the electronic medical record? Do we have a biologic body map to sort of say, what are the parts that are there? Right? It is important, and sort of one of my aha moments in learning about transgendered health is that I thought, okay, person is born one anatomic sex, they say this is the wrong one, they transition, which means transition means you start at one and you can go to the other, and then you say, ding, I'm done, like sort of microwave soup. Okay? But the reality is that in transitioning in terms of that sort of fluidity, transitioning may be enough for a transgender patient to just bind their breasts rather than sort of have a mastectomy. It may be enough in terms of having a hysterectomy rather than creating sort of a penile sort of, implant type of device. And so our perception of what's enough to say that you're to hear, actually we have to kind of throw out the window, because it's up to that individual in terms of how much needs to happen to sort of say, I'm good. And sometimes the transition has economic issues. I can only transition so much because of finances. But sometimes it's like, this is all I need in terms of being sort of affirmed in terms of my sexuality. I mentioned the importance in terms of data and the challenge in terms of data. And sadly, as of March 29th, the current administration is taking out of the 2020 census questions in terms of how many LGBTQ folks are in the country, which I think that as we look in terms of the elimination and deletion of data, whether it's about rape or sexual assault, whether it's about LGBT, really is sort of pretty awful, and we need to have some advocacy to change that around. Certainly sexual orientation and clinical interviewing is important, but again, and here's some videos that actually are useful in terms of sexual history taking. You are very aware of all the different ways we can teach what we teach and how we teach it, and all of these are sort of fair game in terms of inclusion from a population perspective of sexual minorities. For cases, even if you don't actually create a case that is about sort of an LGBT sort of patient, we can always sort of do it on a patient and then say, what if they were? How might it be different? How are the health disparities different? How might this change the story? The what if prompt with facilitator answers sort of helps in terms of addressing sort of that, flipping the patient. And looking at case series review. Oftentimes when people sort of do a whole series of cases, they're not aware that, for example, I'll give you an example. Back when we started the problem-based learning, we got cases from Harvard and New Mexico. And we learned some really important things from these cases that we bought. Number one, every man was an executive or a banker. There were no, the women were only secretaries, and there were no people of color. And then when they started putting the cases, only the people who were people of color died. So it was not a good story. But you had to sort of look at the cases to be able to do that. So in terms of putting in the curriculum, we need standalone and integrated. It needs to be reinforced. Sometimes the identity is used for diagnoses. Sometimes the identity is in terms of lived life, so we understand that component, and we reevaluate the impact. As I mentioned, just focusing in terms of sexual health only is not, in general, we need to give enough time, address attitudes and perceptions, and again, not marginalize the population by looking at them as disease and deficits, that every gay man has HIV, that every woman has an estrogen unopposed sort of cancer risk. And thinking about the oversight, the meta-message of our cases, what do the learners learn that we don't say directly but still convey? Do we have an adequate and diverse representation in our cases, vignettes, SPs, OSCEs, and simulations? Do we surveil to make sure we don't teach about stereotype and make sure on an ongoing basis that we have an inclusive environment? Other real-life examples, giving bad news to somebody who you don't know who their significant other is. Handling the oops and ouches of presumed heterosexism, tell me about your husband, to a lesbian patient. Addressing substance use and partying within gay culture. If you have no idea how to party in gay culture, you're kind of flat-footed, right? So you need to say, tell me what you do when you go out and have a good time. And so I can understand in terms of how to do harm reduction for you. Understanding terminology about sexual behavior, being a top, being a bottom, what that means. Eliciting sexuality when people are living within rigid sex norms or expectations, or an individual sort of being on the down low in terms of living sort of this heterosexual life, and yet their behavior is sort of with same-sex partners. Invisible lesbian patients that we don't even know what they are because they don't bring it up because they're afraid and we don't ask. Patients being uninformed about sexual health risks and being avoidant of healthcare interactions. A powerful experience I had when I was a medical student is one of our affiliates. I was in this rotation and there was a lesbian patient, and this lady had diabetes. And she came in and she was on the oncology floor. And so we go to do the physical exam, and her left breast was a rock. It was all metastasis. It was a rock, clearly something that had been going on for a super long time. And so I had said to her, like, I guess other than this, your health must have been really good and you haven't gone to the doctor. She says, oh no, I have diabetes. I go to the doctor every month. She went to the doctor every month. Never once did she get into a gown. Never once was her chest looked at in terms of having this metastatic cancer. Range of what is enough for transitioning patients, as I mentioned. Screening for intimate partner violence. Rates for IPV are the same, straight or gay. Everybody gets to play. So we need to ask everybody in terms of safety and healthy relationships and screening in terms of transgender patients. We don't have time to play Jeopardy, but there are things in terms of sort of playing Jeopardy to sort of do the terms and get people to know and get them interested in terms of doing that. So use sort of your innovation and sort of fun piece in terms of sort of conveying some of these people. Take homes, check in for collective awareness about Sexual Health 101 in terms of these elements. Augment faculty education with continuing education on the topic. Engage your students in learning, matching your clinical experience with potentially their awareness about sexual minorities. Evaluate when you teach population health and replicate that system for sexual minorities. And ask the meta-message in cases, assess the meta-messages in cases to assess cultural effectiveness. Thank you. Questions? Yes. Mm-hmm. 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 Great question. Okay, so let's back up a little bit. Number one, if you currently are breathing and your pulse is active, you have cognitive bias. It is part of humanity. The fact that we don't go pet the lion, nice little kitty, nice little kitty. We learn it like, no, that's a lion and that's a little kitten, and I sort of know what's safe and what do I fear. So cognitive bias is a human experience. We have it, okay? There is overt bias, and then there is covert bias, okay? And the challenge in terms of some of the issues is that for most people, it is not the covert bias, I like this, I hate that. It's the stuff that's playing in the background that we don't even know. So if you go to implicit.org, there are sort of these little tests that you can say, do I tilt heterosexual to gay? Do I tilt man in science versus woman in science? Do I tilt in terms of race, ethnicity? So there are ways to sort of see, how do I tilt? Because that's what my unconscious is doing. And the only way to drive our unconscious is to shine the light on how do I tilt to actively do it differently. Otherwise, we will say one thing and we'll do another. So to your question in terms of sort of awareness, the only person that you can absolutely have insight and know about is you, unless you dissociate, and that's a different thing, and we can talk to a psychiatrist, but the reality of you have you. So you can sort of say, from my experience, how I was raised, because I would submit to you that Indian culture is not the only big dinner, multi-starch culture that exists there, right? But you can say, from my culture, this is how we roll when it comes to dinner. And so I can tell you, this is my challenge I would have facing diabetes. Now tell me about how it is in your culture, okay? And so it's sort of shine the light. And it goes back to that individual versus culture thing. You know, I might have been raised Catholic, but what do I do in terms of lapsed Catholic? Like, what do I do in terms of various beliefs? And so if you just say, oh, that person's Catholic, and I now know what you are, what you believe, and what you do, that would be flawed. So I say, sort of, how do you identify? And then of those things, which ones of those do you do? Then we sort of balance. Because we can't know about every single culture. All we can do is actually use the same skills that we use for clinical medicine, right? We don't have to have migraines, lupus, heart disease, stroke, all of these things. We don't have to have all these things to understand them. If we would, we've had very short careers. In truth, what we need to do is say, tell me what you have and how is that like for you, so I can understand. And in that same cultural piece, tell me from whence you come, what your folks do, how you do things, so I can sort of help in terms of sort of harm reduction or understanding the implications for your health. And so I think that that's sort of a piece of it. But first it starts with sort of doing some quick little tests to sort of say, what's my unconscious bias? To share with you how important unconscious bias is, there's studies where they've actually just asked ladies to walk a city block back and forth. Okay? Very simple. All they had to do is multiple times walk back and forth. And they were videotaped. And one of the times when they were videotaped, and African American youth came on the sidewalk opposite them. Okay? To a person, the ladies either moved their purse to the side opposite the youth, or they actually switched to the other side of the street to actually not walk past the youth. Now, that's not the big aha moment. The big aha moment is they interviewed these very nice ladies who got money, nice stipend for this little behavioral study. They were happy. They asked these ladies, how was it for you? They said it was fine. It was easy. Easy check. I said, did you notice anything different as you walked back and forth? No, it was pretty much the same. And then they showed them the video where they moved their purse to the opposite side, or they moved to the opposite side of the street, and they had no memory of doing it. That's the power of unconscious bias. Good intentions are not enough. Intentional actions are what we need. And the only way we get there is we sort of do the work to look in terms of our unconscious bias, because we may be very pro-LGBT, but if we're not in touch with that unconscious bias of it makes me nervous, or I'm a little bit uncomfortable, I don't know what to ask, what do they say in terms of if I ask them what do they do and I go, oh my gosh, really? We have to sort of deal with that. And so shining a light on unconscious bias, watching sort of videos, learning sort of about the culture, I think is the way to do it, but kind of do what we do in terms of what is having chest pain like for you, rather than here's what the book and this is what it says, but it might not be for you. So tell me how your experience is so then I can sort of help you in terms of sort of that, where we move from here. Great question. Other questions? Thanks.